My name's Magdalena Harris. I'm also a peer, and I'm based at London School of Hygiene and Tropical Medicine, where I'm an associate professor. And I think, is that one not working? No? All right. So, but we need this one to be working so you guys can present. I think it's working. All right. Is that working? Do I have to go like this? Okay. All right. Okay. Great. Well, I'm pleased a few more people have joined us. I know we have some stiff competition from other parallel sessions. But as I said, I think this is one of the most important ones, and that this is where, activism and peer-led organisations are the key, obviously, to getting this harm reduction agenda, off the ground and improved. And I think, we should be mindful also that in 2021, government signed a new global AIDS strategy that commits the world to community-led organisations delivering 30% of the HIV response. I think we should be more optimistic than that. I think that community-led organisations should be doing at least half. And what I'd like to do is just hand it over to the peers actually, instead of keeping on blabbing on. But so first off, I'm very pleased to introduce Antoniu Llort, who's a social anthropologist by background. He has a PhD in social anthropology. He's a long-time activist and promoter of the Catalan network of people who use drugs. He's a past member of the EuroNPUD board. And he's going to be talking about peer needle patrol, NSP machines, and community solutions to injecting issues. And it's a real pleasure to hand it over. And people, think about if you have questions, you want to engage in debate with the peers, keep them in mind, and hopefully, and we'll have time for discussion at the end, but hopefully a time for everyone to have a couple of questions after each presentation. Cool. Over to you.
I prefer that. Good morning. It's a pleasure to be here with this youngsters activist. And my name is Antoniu Llort. I'm a CATNPUD co-founder and activist. As a researcher on community health programs as well and harm reduction. And I'm going to present you a peer-led project that consists in facilitating injection solutions for the community. In my town is Reus. Well, CATNPUD is formed by 7 or 4 networks in Catalonia. It's a Medicineres, a Women Who Use Drugs network, AUPAM, SAUPAM, even so the Catalan Federation of Cannabis Clubs is included in the network. And please don't forget to visit our website. There is you can find a very nice videos and pics of our campaigns. And well, Reus is 1,100 population, a small town on south of Barcelona. And ARSU is one of the networks of CATNPUD. There is a municipal plan on drugs since 1990, more or less. And this is a great plan which addresses multiple ecological factors to explain why people who use drugs, not criminalizing, not stigmatization, and offering the maximum access to all facilities on town. Well, what is ARSU exactly? It's a drug users network since 1999, based in Reus. This is the first newspaper in Reus of 1999. Collecting challenges is the main title. Basically, as a self-support group, we based our interventions in the weekly meeting. It's very important to set always the same date, the same place with great people. We are always 25 or 30 people every week in our meetings. Let me show you a few pics of our last meetings in assemblyary way. This is a drop-in center in town as well, where it's the office of the Drug Users Union. We perform a lot of campaigns, also like Sopra Dampanis, etc. Do you know perfectly? We advocating as well for housing or dignity for drug users as well, not only drugs. And at least we provide a big range of harm reduction facilities. But for introduce a little bit the data on Catalonia, in the figure number 1, you can see the annual evolution of distribution of sharings since 1993. We're now stabilizing on 1.2 million of sharings in a population of 7 million. It's Catalonia, more or less. The figure number 2 is the distribution by type of services. Most of them is from harm reduction services, 70%. The other big range is pharmacies and primary care centers, and a few mobile units, street outreach workers, and exchange machines on the street is 1%. This is what I'm going to tell you today. The figure number 3 is the distribution of sharings per 1,000 inhabitants by health region. In Reus is in Camp de Tarragona. We are above 63 sharings for 1,000 inhabitants. Okay. This is our action and outreach work map. Do you like to mapping all our work? And you can see the drop-in in the middle city. This is the hot area, where is the shooting galleries you can buy in this red triangle. We have the machines exchange program, automatic machines on the street, 24 hours. We get very closed emergency rooms. You can do the exchange as well, 24 hours during all day. We have a pharmacy 24 hours as well. And then this network of different points to access to material to inject is available 24 hours, 365 days a year. Well, this is the specific program. You can see the 2 machines. The name is DP, Diversification of Exchange Points, to guarantee 24 hours the accessibility to the materials, complement of other exchange points, as you see before, inform drug users on the streets, and increase the access to the facilities of town. The most important, maybe, it's one of the points to discuss today, is that project provides a micro-employing and microcredits line. We have a budget for this project about 7,000 euros a year. It's not so much, but it allows to pay 100 euros for one peer every week. I explained you after. There is a data of our exchange machines program. The orange line is the sharings collected on the streets, and the blue is sharings delivered from the machines. It's not so much this in 2020 for the COVID situation, but I want to highlight that during COVID lockdown, EHRC don't stop to deliver harm reduction services, drop-ins during the lockdown as well. Is that maybe the only NGO working during the lockdown in town? And how we do? As we said, we are 25, 30 people, activists in the network. To engage with this project, DP, you have to attend the meetings. This is the only important thing to do. As well, to participate in this project, you have to be trained on Naloxone, on safer use, hepatitis C prevention, etc. And we have 400 euros a month for this project to go directly to the community experts. Also decide to slide this money, and then it's not 400 euros for a week one person, if 100 euros weekly for each one. It's more fast to change the participation. You don't have to wait a month. And you have to surveillance and maintenance the machine every day, Monday to Monday. It's not weekly, weekend time is not exist. To attend the people who is around the machine as well. Not only people who wants to inject, the general public as well. We have to be involved in pick-up sharing campaigns weekly with our patrols and prepare kits for another exchange points. This is the work you have to do to be employed in this project. This is a piece of patrols, of ARSO patrols, preparing to the campaign of cleaning shooting galleries in a semi-rural area. There is a lot of shooting galleries in between all the structures or in caves, even so. Well, some highlights from this project. We think that we have a strong support system, peer support system, collaborating with other facilities. And if you see this wheel, you can use it on streets. You can get engagement with ARSO, training, engaging the network, participation in this micro-employing project, became an activist, of course. If you are free to go out and enter again without any expectations of you, any requirements. We think that we are contribution to an improvement of epidemiological data. For example, a number of cases of new hepatitis C infection decreased from 20 cases in 2009 to 0 in 2018. Maybe data of 2020 is 1 or 2, I'm not sure, but it's a very good data. To participate in conferences like that, to interact with other activist groups is a very important thing to us as well. To impact in the local media, because we are a very little drug users union, but every people in town knows ARSO, and it is very important to be in the local TV or in the newspapers. We try to call them in every campaign. And a few challenges I want to share with you. It's very difficult for us to strengthen and maintain our network, and we want to increase budget to pay more peer work, more trainings, more conference. We have very little money. The second one maybe is the most important, and maybe this evening at 4, in the major session number 5, there is a panel about research and peer work. We want to implement research systems, qualitative preferably, to measure exactly the real impact of our actions, not only in epidemiological way, look for the quality of life, etc. Implement drug checking services for all the users in town. We're working on it. Maybe the next year we have a new point with TLC. And finally, advocate for safe supply programs, not only heroin, and for a full spectrum harm reduction facilities. I hope I am explaining so bad, but now we have the opportunity to ask me, and that's all. Thank you.
Is this on? Yeah? Okay. Thank you very much. That was amazing, really inspirational. Does anyone have any questions? Great.
I think it's interesting to understand better, maybe here, what do you intend or what do you reclaim by safe supply? what you are doing in this sense.
Well, we are now with a little grant from EuroNPUD raising a campaign about safe supply in Catalonia that involves cannabis clubs, drug service checking, and as well we are an advocacy campaign to the Catalan government to implement programs of injecting heroin, legal heroin, in an observational project. And even so, we are looking into the Vancouver municipality, who is now allowed to compassion clubs and supply heroin, cocaine, methamphetamine, providing from the black market, but checked by the drug services. And we are working in this proposal.
In the slide you had the pharmacy and I had just the exchange machine, 24 hours. Is it free or it's working with coin or?
No, it's free. It's like a coin, but it's not a currency
Yeah,
money.
it's a bullet.
Yeah, it's a coin, I don't know. Yeah, even so, during time, the machine accepts 5 cents of euro. Not in the beginning, but people is trying and trying and trying. At least if you have 5 cents, it's okay as well.
Okay, cool.
How do people get the token? How can they gain the token?
How do people get a token? And where do they get the token?
How you can get the token? You can get token in every point. But even so, the ARSU people is always surrounding this area with tokens in the pocket, but you can achieve tokens in every point.
So I think we'll move on to the next speaker just so we have time to get through everybody, and then we can have time for discussion and draw out, commonalities and differences as well at the end. But thank you very much. Do you want to close that? That's the next one. Okay. All right. So next, I'm delighted to introduce Emilia Piermartini. Apologies for my terrible pronunciation. So Emilia is a member of CASO, the Portuguese network of people who use drugs, and also the Italian network of people who use drugs, and EuroNPUD as well. And she has background in anthropology, like our last speaker. And Emilia is going to talk on peer-to-peer NSP and the response particularly to COVID-19, and to reflect on the Italian and Portuguese experiences. So take it away.
Thank you, Magdalena. I am very nervous, and you already made half of my presentation, but thank you. I'm going to blush a lot. Yes, I am part of CASO, Portugal, ItaNPUD, and EuroNPUD, as you said, and today I'm talking about CASO's activities during the pandemic, especially in the territory of Porto and in online meetings. CASO born in 2010 officially, and we are mostly active in Porto and Lisbon. When I'm talking about these outreach and advocacy activities, I'm referring to Rui Salvador activities for the outreach ones and Rui Coimbra for the advocacy ones. Just to have a bit of a context, we already know the Portuguese model, the decriminalization model, and the most important part is that harm and risk reduction become part of the Portuguese drug policy as a pillar. Drugs remains illegal, but possession, use, and acquisition are not more a crime, even if we have silly thresholds. And it's, of course, a lot more than this. And during the pandemic, Rui Coimbra, involved in the risk-reduced network, made more online meetings than in the last 20 years. Maybe in, yes, it was very overwhelming. I mean, it was a lot of work, and in this period, they were involving also Regional Health Administration and the General Directorate for Intervention on Addictive Behaviors and Dependencies. About the outreach activities, before the pandemic, the harm reduction, the low thresholds harm reduction services in Portugal were distributing methadone and safe injecting materials and also other treatment, drug treatment, and every day. But with the pandemic, I'm talking only about the Porto situation, they stopped it for several months. And so a daily routine became a monthly routine. In this occasion, Rui Salvador stepped into the situation, joining the activities of the volunteer outreach team Saber Comprender. Before the pandemic, they used to go out every 15 days, and during the pandemic, they switched to twice a week. They were used to provide cold meals and hot and cold beverages. And with the pandemic, they started providing hot meals and safe injector material kits. This was a great effort, and these are the items we were able to distribute just from April to December 2020. As you see, this is the list. I'm not going to read, but yes, this was really a big effort from the peer workers, and stepping into not the gray area, an empty area leaves from the institution that were unprepared, not only in Portugal, of course, but all over the world. The institution were unprepared to this pandemic situation, even if it was somewhat predictable. Thanks to our activities, we were able to finally enter the National Siring Program that before this date was, it has high thresholds to enter, and now we are part of the program, so we have our own supplies. Of course, before the pandemic, we had supplies from our allies like UPDASH or SAOM, two NGOs from Porto, but now we have our own. And we contributed in a meeting from 25th to 27th of November for the next national strategy. And we found home to some people in need during the pandemic, where while the institution were forcing them to do 14 days of quarantine, we tried to, we have been involved in the process, and we try to don't left anyone behind. Yes, what I want to reflect onto with you, of course, so I'm open to questions, is that it's kind of an obvious thing, but peer work is work, and it's not just to be, it has not to be valorized just in the emergency situation. We are part of the community, and institutions need to involve us actively and directly to know better the world, because they still are very far from the reality. And yes, these are my conclusion, and I thank this partnership we had, Saber Comprender and other NGOs and other partnership we had. Thank you.
Thank you. I like what you said about peer workers' work, and I think that reflects also on what Antoniu talked about in terms of funding and, you know, the importance of having proper recompense and money for peer work to take place. Could you talk a little bit about how this work is funded, who's paying for the outreach, how you cope, or how you advocate for decent recompense for your work?
Thank you, Magdalena. So the most part of our funding comes from EuroNPUD. We still don't have any national funding, and this is putting at risk our activities because, as we know, we have to eat, we have to work, and so it's very overwhelming for the people who are involved into these activities. I'm talking about money funding, of course. So all this partnership gave us resources to use, like spaces or kits or time or challenge and time to grow and to learn more and to learn with. But the most resources come from international projects.
Great.
Thank you. Thank you for your presentation. I was just struck, you talked about the effects of COVID-19, and we're obviously all messing around with our masks here. Would you say that it made those institutions more open to collaboration with projects like yours? And if so, how do we make sure that it doesn't just go back to normal now that the masks are coming off our faces?
Big question. I don't know if I can
Yeah, I know.
answer completely. I mean, yes, I think that institutions in the bottom are composed by people like us, and I think that at the bottom of the institutions everyone is perceiving the situation and knows the limits of the policies or the fundings and this kind of stuff. If this is reaching the upper past, I'm not sure. we have to, this is our challenge, I mean, to let them understand. But it's not just from people who use drugs, it's from civil society and also the bottom part of the institutions, I think.
Thank you very much.
Yes, I just want to comment that maybe it would be easier to have direct funding for the community organizations, not catering civil society altogether, but whenever we would like to be able to run to specific services and learning services by peers, for peers in sex work, drug use, bringing different intersections here. And the problem, and most of the times we can't do it or employ our peers more, or just living from the international or European fundings or small grants, is because we don't have direct funding for community, even in this country, with the decriminalization and harm reduction background.
Hello, I'm Mark. I'm a medical student studying here in Prague. I work in the contact center in Sananim for 2 years, and so I come from because I'm a medical student, I come from a little bit different background than addictologists and other specialties. And I was wondering, how does it actually work with peer workers regarding to the use of drugs in the time of work? That I'm not quite familiar with this topic, so excuse if it's a basic knowledge and everybody knows it. Thank you.
Thank you, Mark, but I'm not a peer worker, so maybe I should pass the torch to someone else. I'm not working in such an institution.
I can kind of speak to that. So I'm from Canada originally, and in Vancouver, we developed peer services. And that was a big part of the conversation because we didn't want to not talk about use. Obviously, we wanted to, embrace it and have conversations around it. So they developed a thing that worked for them, and it was a peer-led kind of foundation of peer services under a system of like well, not high. So someone could be using, but like if they were having issues where they weren't able to like support somebody else, then they would just have a conversation like, hey, are you okay? You know, do you need support? And it was just always about context, always person to person, There was no kind of like 3 strikes and you're out. There was no kind of, you know, box structure that if one person didn't fit it, it was always person to person. So it's kind of how they did it there.
I think in Portugal, it really depends on the organization working with peers. For some organization, it will be okay, and also the flexibility regarding the peer work. Yeah, I'm looking to my peers as well, and some others are more restrict. So there is no regulation around this, and also no single solution.
For us, our organization, our example is not an issue. If you are hired or not, you have to do the work, and that's all.
Okay, thank you. Well, I was wondering, how do you communicate this issue to a different service that it's not peer-based, when you have to cooperate with somebody else and they ask you, well, what if this person is intoxicated when I will be standing with and representing us and your service to maybe a third party? That the issue of communicating this to the outside world.
So there is a set of guidelines written by the Alliance for Public Health and COACT, which are best practice guidelines on employing people who use drugs. So I would recommend those to you. If you search good practice guidelines, people who use drugs, you'll find them. The mechanism that we highlight is that we're asking people who use drugs to use our privileged access to engage the community. So you're using the fact that we have those connections, we're engaging. Sometimes you might be using the moment when we are actually buying drugs or using drugs, and we're also giving harm reduction advice, education at the same time. In that context, if I'm in a crack house giving advice to my peers, being intoxicated may actually be very helpful in terms of the process, because it means we can talk about the practices we're doing. If I'm making a presentation to a conference, then you would expect me to be able to manage my drug taking to such an extent that I can stand up in front of you and make a presentation, and do you know that I'm using drugs or not? Well, that should not be the issue. The issue is, can I functionally present to you? So in our employment guidelines, it's always, are you able to do your job? And if we're asking people to take additional risks as drug users, we need to also offer them additional support and recognise that no, that is not a neutral process. We're asking people to take risks on our behalf as people who use drugs.
Okay, thank you.
And also, I think that when we are using peers and people who are active drug users, we have to understand that for them, using is the same that sleeping and drinking or eating is for other people's. So you cannot expect that somebody who's in active addiction or using can stay without the daily doses just because you want to go to the third party and have a presentation. But for me, it's always the fact that if you are able to stand and speak, that people can understand you, then you are ready to work.
I'm also a peer worker, and I use drugs. I've been working since 2014 for an ONG called Portugal. And what I think is you can't start from the point of view that we are always working intoxicated. We are drug users as we take medicines, as people drink alcohol. Usually in the drug settings is where, as Matt told, we many times give harm reduction and we reply our practices because it's easier to empathize, and you add some responsibility. If you are inside an activist yourself and you want to reply what you are taught of, you gain an empowering that gives yourself that responsibility to give it in the best way. Of course, we take care of each other as we are standing here trying to make you see that it's not a general, I think we can start from the point of asking that we are delivering intoxicated. In all society, people drink alcohol, and we don't stand asking if they are able to give their service by being intoxicated. So as we drug users, we are not blamed for, we shouldn't be blamed for the prohibition, because the prohibition is what makes people stand for these questions. A drug use, it's like any other thing, and you shouldn't ask that we are, from the beginning, working intoxicated. We take care of each other.
Just one brief final point. You wouldn't expect a diabetic to deliver a presentation to this third party without their insulin, because they wouldn't be capable of delivering the presentation. They'd be ill. This is the same for people who are dependent on opioids, but it's possible to be dependent on opioids and be completely coherent. So, yeah. Okay, thank you.
I think that's a great debate, actually. I'm really pleased that we had this conversation, and I mean, from my perspective, I think it would be more of a concern to expect somebody to work if they didn't have the drugs that they needed, and that probably people would be more obviously unwell and incapable if they were dependent on opiates and were missing their dose. So I think there's a difference between being intoxicated, as we might think about intoxicated, and being well, being normal, you know. If you're dependent on heroin, you need your hit in the morning to be normal, to function just like everybody else. That's different from being intoxicated from my perspective. So I think it's a really good debate to have, and a good question to have and think about also what happens when people do become intoxicated, you know, because drug use has its ups and downs, and we all like to take things to the limit sometimes, and then what are the supports and what are the things that the organisations put in place to help carry people when sometimes their life gets a bit messy or whatever. So I think these are important discussions to have, and I'm really pleased to see the room so full now. It's wonderful. Yeah, it's fantastic. It's such an important session, and I'm delighted to introduce Joana Canedo, who's an activist and a EuroNPUD campaign coordinator. She works particularly with women and non-binary people at CAT Portugal. She's an expert in drug policy reform and harm reduction, especially focusing and engaging women dealing with multiple forms of violence. And so it's a real pleasure, and take it away.
Thank you, Madalena. Yeah, maybe easier. So I'm here to speak you in behalf of Richard that couldn't join the session. And what I've tried to bring you is information about, well, information and discussion, because I think we've already proved this is an horizontal space, and every time you want to question, please do it. About Naloxone distribution, this is still an issue. I've heard several panels on this topic and referring to Naloxone use. But what I would like to bring to here and to talk with you is like the way to reduce barriers when accessing Naloxone. So EuroNPUD during the 2020 and 2021 did a peer-to-peer Naloxone technical briefing, and then a one-day course, Naloxone Saves Lives, that has included a toolkit, a guide to trainers, and also a PowerPoint presentation that might be replicable and translated in any language. We know already from the beginning that peer-led harm reduction has privileged access to drug-using venues, drug supply systems, friendship networks, marginalized communities where many drug users live, self-support groups, technical know-how, shared lived experiences. I think this one is the most important one here. The main guidelines of EuroNPUD toolkits are around, of course, peer education, the importance of knowledge in preventing and managing opioid deaths, identification of signs and symptoms when calling the ambulance, managing the casualty who is in consciousness and breathing, who is unconsciousness and not breathing, and the naloxone administration, basically. But we know that sometimes, especially in street settings and also at home, when we deal with an overdose, it's not so direct the idea of, for instance, calling an ambulance, because it might happen that with the ambulance comes the police, it might happen that you have your children home, you might happen that you are a tenant of, an apartment, and sometimes this is one of the motives that actually brings us to less action, especially if we don't have nasal or injecting naloxone with us. And this is something that I would like to also hear from you, which are the strategies that you work together with our communities and peers to kind of decrease this fear of recalling on the emergency, because we felt that this in several moments. Then, of course, EuroNPUD underscore the centrality of the involvement of people who use drugs. Their drug users must be regarded as the primary target group for naloxone distribution and administration. And for avoiding episodes like this one, if we all had our naloxones whenever to revert opioid overdose, it will be at least a good principle. So the rollout of naloxone still remains suboptimal and preventable. We could prevent more lives if we had more of this. So peer-to-peer naloxone distribution, how to engage. Different users can be engaged by professionals. This is one of the options when peers go to professionals and, for instance, are paid for having training and for then multiplicating the naloxone among the communities. It can happen that actually the agencies can contract their drug users unions, groups or organizations directly to make the training and to make the distribution, and probably you will arrive to more people because you don't have to go to a service or to an emergency service or to an harm reduction technical service to ask for training. And then the naloxone, you just are employed by any government agency or through NGOs to give training to your communities and to split out the naloxone. And then there is also an option that internationally drug users group have also worked autonomously in distributing naloxone and deliver peer education. This happened lots of times also in conferences to do peer-to-peer naloxone training and distribution. We know from already that scientifically the United Nations Commission on Narcotic Drugs recognized the expand of naloxone as a plus to reduce overdose-related mortality. Of course, here we are talking about opioid overdose. Naloxone is also included in the World Health Organization essential medicine lists. Nevertheless, we've seen now with the launching of the Global Drug Policy Index that came out last week that only 3 countries in 30 countries have take-home naloxone programs, peer-to-peer distribution. So 3 and 30, of course we are not talking about the entire world, but it's very representative sample. These 30 countries were elected by loads of community members and experts in drug policy, and this evaluation was made by experts and community again. In between, among these 3 countries, we can find actually 2 European countries, which is Norway and UK. I don't know if anyone from UK and Norway here that can actually give opinion or feedback on how these take-home naloxone programs work. In Portugal, we still don't have any take-home naloxone program. What happened is that for the first time back to February 2020, by the time I was in Barcelona, but when I came back, I realized that we had naloxones, but they were already expired. So when they were given to NGO, harm reduction teams, they had 2 months of praise. I don't know if it's the word, praise. And then they became expired. And of course, you might have 6 months for using it later, but you really don't know if it will be working or no. And you are actually teaching your communities, your peers, to use expired medicines. So we haven't had access to Naloxone until now. I think now there was a new distribution. But we didn't give up of giving training to our peers. So together with CASO, in 2020, and supported by EuroNPUD's grant for International Overdose Awareness Day, 10 peers were giving train by Rui Salvador, I think, no? And we used these naloxones that were remaining expired to distribute informally to the community. So it was not a formal distribution, but it happened the same because they were stopped there. And supposedly, Mundipharma told us that we had 6 more months to use it. So we did the same in Lisbon, and with the polydrug use prevention overdose administration of naloxone, with a peer bursary that is, well, it's attached to it was attached to the first mobile drug consumption room by the time. And this campaign reverted also in distribution and training of at least 20 people who inject drugs, opioids in this case. In the drug users development grants, which is again a project in between GAT and CASO, we are fighting against the stagnation of drug policy itself, because after 20 years of decriminalization, we still have street access to naloxone. So it's written everywhere that it's more about emergency availability and not community-led dispensaries. So we consider this is like a major failure when regarding the protection of our communities, and that we don't need description. It should not be necessary to have a description to get this. So whenever the CADs, like the Center of Addictions, doesn't give to the teams to later be distributed, we have to have a medical prescription, and it might take us time, efforts, and the absence of this has made actually increasing relatively the numbers of deaths along the last years. So some challenges that I bring you for discussion here. Supporting pharmacy reception staff to be naloxone champions. So naloxone will be widely available and free, okay, for drug users. Maintaining peer knowledge levels and reinforcing positive community norms. Making naloxone distribution routine for people in drug services. So it means that most of the times also it can happen in other countries that I've worked and traveled, that the naloxone does exist in the services, but it's not distributed to the people. Ensuring access to naloxone for people who use injecting drugs in prison, and also when people leave prison and hospitals, because we know there are more probabilities of happening opioid overdose. So please engage in the discussion, bring me your barriers from your national realities. We would be happy to listen to it, I think. Thank you.
Thank you. It was a great presentation. I mean, it's shocking that there are so many barriers and that it's still so strict. And I think you've provided a wonderful invitation to the community here to reflect upon challenges that you're experiencing, or perhaps ways through the challenges. Does anyone want to provide comment or have any questions? Yep.
I'm Nicholas from Sweden, and I think we have the absolutely most stupid thing in the world. You could get naloxone from the governmental syringe and needle exchange, but there you have to have an ID, and you don't have to have kids and so all that. But it's written in your name, and only you could use it on yourself. That's according to law. So if I if I use mine on someone else, I could actually go to jail. It hasn't happened yet, but that's the way it is, because the law says that someone who has not a medical training has not the right to give someone else any medication without its own, that the person says yes. But if you're overdosed, you don't say yes or no, you just happen to get it. And the naloxone as well, you could get it from 5 or 6 places in the country for free. Otherwise, one of those boxes are €41. And you can imagine how many are actually, and we actually been executed now. The police has been raiding us a couple of times and taking away what other people sent to us, because that is the same crime to give out naloxone as to give away drugs.
So just to let people know, at the front here is some hard copies of the EuroNPUD reports. One is the technical briefing on peer-to-peer naloxone. The other is an audit of, it's called the Naloxone Access and Advocacy Project. It was a peer audit of take-home naloxone. Once we did it, we really decided that peer-to-peer naloxone was so substantially more effective than take-home naloxone that we actually moved away from auditing take-home naloxone and have really pushed for peer-to-peer instead. Just watch out, they both look very similar to each other, but they are 2 different reports. We've got a version in Portuguese about to come out, and all of our resources are set up so they can be easily translated, both the training kits and also the technical resources, and we mean both translating and also tailoring to national context. So we've got money set aside to help. Portugal is the first country to go down this road, but if other countries also would like to explore developing these resources, we want to take away the cost and help have peer-friendly resources very cheaply available in the country.
Thank you, Matt. I think there was one person who had a question. We could have time for one very brief, yeah? And then we will move on and hear about naloxone in Ireland.
Just to reinforce my colleague's Joana words, in Portugal, as a well-seen model, in fact, the naloxone is not always available. During the COVID pandemic, there was a rise in the heroin intake. I've seen in the last 2 months myself 3 beginnings of overdose. And I think we should reply in the drug consumption houses peer-to-peer the naloxone. Actually, the services are provided with almost ending naloxone expire date. It was a way to contour the system and have available to give. Also, there's a lot of migrant community that during the pandemic stayed unemployed, and they live in a lot of shame by their own communities, and I think we should address that also because they are very marginalized, and we should come out and have help to give peer-to-peer in place the naloxone to save lives.
Thank you. All right.
Does anyone here doesn't have naloxone or had an episode and would need naloxone for taking for your country? Because I actually had the privilege to have this one, and for the next months I wouldn't have, but I will give one to you and another to you. Is that okay? Mm-hmm.
Thank you. Thank you very much. That's wonderful. All right. Yeah. Okay, it's my pleasure to introduce Lynn Jeffries, and they are originally from Vancouver, Canada, currently based in Dublin, Ireland, And Lynn works as peer support worker for an advocacy service for people who use drugs, and they're going to talk about distribution of naloxone to educate and mobilise peers in the Republic of Ireland. So take it away, Lynn.
Thanks. You just did my introduction for me. That was the first part of my presentation, so there we go. Hi, my name's Lynn. So, like Magdalena was saying, I'm based in Dublin now. I lived and worked in the downtown east side of Vancouver, BC, on unceded Coast Salish territories for 12 years. And I started doing harm reduction work in 2010. I moved to Ireland in 2016. So I'm going to talk to you about peer-to-peer naloxone in Ireland. I began working for an organization called EHRC in January 2020. We're a small team of 3 people who work with and for people who use drugs. We advocate for peer empowerment and peer-led harm reduction, both regionally, nationally, and internationally. So one of the big issues we face in Ireland is the lack of up-to-date data regarding drug-related deaths. The last information we have is from 2017, so it's a good 4 years without data to respond to in real time. From the data we do have, we can see a trend of about 1 death per day. We know that 3 out of 5 of these deaths involve polydrug use, 1 in 4 involve methadone, and that 97% of people who were injecting at the time of their death were using opiates. So the take-home naloxone project was approved in 2015, and in 2016, a recommendation was made to address the challenges of reaching people most at risk, including doing outreach, easier access to resources, and delivering the training clearly and briefly. In 2015, there was a medicinal products regulation that was amended to improve access to naloxone by exempting the administration and the supply if a person has accredited training. So this accredited training, today there are 9 private companies in Ireland that provide that accredited training, and the cost is between €80 and €500 per person. And you have to get it updated every 6 months to 2 years, so it's very inaccessible. Despite this, the amendment, it's still inaccessible. It's still prohibitive to frontline responders and for peers at risk. So despite these barriers, EHRC and other services in Dublin and in the rest of Ireland continue to work flexibly within the public interest. EHRC has trained over 250 people and distributed 200 kits. We provide our training for free. Recently, the intranasal naloxone has become reimbursable on the medical card scheme, so it's a bit more accessible for people in terms of cost. And it's a big step towards making naloxone free and legal for everyone to use. So we began our naloxone training during the early months of the pandemic. We produced COVID-19 overdose response resources in English, Lithuanian, Latvian, Polish, Russian, and Portuguese to meet the needs of the population that we were working with. And because of COVID-19, like Matthew mentioned, like services were responding pragmatically with more communication, less red tape. We really kind of saw the beginning of what we could do if we worked together. Hotels for tourists were shifted into emergency shelters, and redeployed staff found themselves working with new demographics, so many of them were not trained in overdose response. And this is where we had our first naloxone training session. It was at a cocooning unit with 9 staff members. And shortly after that, we trained our first 2 peer volunteers. So most of the residents staying in the unit we were working in were using more than one drug, and most of them were accessing methadone clinics. And during our training, we started working with a GP, so we were able to start providing people at risk with the kits. So we developed that direct relationship. which made it easier for us to develop our peer-to-peer training of naloxone. So each of our trainings for our peer-to-peer is around 20 minutes. We try to use easy-to-understand images, as both our peers and trainees sometimes experience barriers to literacy. And we developed our training based on peer feedback. So we take anecdotal instances of how the product was affecting people, the number of doses, experiences with emergency dispatchers over the phone. So all these things we kind of try to put into our training. And with the way that communication and overdose reporting works in Ireland, it made sense to have people who are living it in real time be feeding back in real time. There's just some questions that only somebody with lived experience can answer. So we currently work, ISCA currently works to co-facilitate the trainings with peers. So we hold the product and supply, and we help with the paperwork and the prescriptions afterwards. We would like to move towards peer trainers that have direct relationships with their own GPs in their own local communities. Ireland is a country made up of lots of local communities, so we would really like to facilitate that. We provide flat rate reimbursements. Very dry mouth. So we provide flat rate reimbursements of €20 for our peers who do shifts. This is out of our own budgeting. It's in the form of cash stipends. We took our advice from the How to Involve People Who Use Drugs. It's a Toward the Heart reference developed in Canada. It's very good, developed for peers, by peers. And the hours and the honoraria are small so that it doesn't affect people's social welfare payments, because that was a big risk for people who wanted to be involved. They didn't want to get kicked off their dole, so we were mindful of that as well. So far we've focused our peer-to-peer naloxone training around 2 important days. For Support Don't Punish, we trained 4 peers who then trained 40 people in 3 different communities. And then for International Overdose Awareness Day, it was kind of special because we gained 3 new peer trainers and trained over 40 people, but we also were able to link in with a second GP who was local to that area, so kind of a step towards that local link with the community. So that was really good. So why peer-to-peer naloxone? Stigma in Ireland around drug use is so widespread, people are afraid to admit that they use. Naloxone, it's about looking somebody in the eyes and saying that you shouldn't have to die. You have the right to life, and your friends have the right to life. Sorry. This kind of affected me, this part that I'm talking about yesterday, is that we forget that the data and these numbers that we work with exist because there are real people who are living and dying through a genocide. And we're here this week to say that we don't agree, that we accept people that use drugs, we support people who use drugs, and we support people to use drugs. And if we accept this, then we can accept the vision of peer-led harm reduction as the way forward. So our vision for peer-to-peer naloxone in Ireland is amending the current law to allow naloxone to be carried by frontline responders without prescription, the acknowledgement of lived experience as a qualification to work in low-threshold services, accessible and accredited training, and peer volunteer programs built by peers and that include people in current active use. So thanks very much for listening, and thanks to EuroNPUD for having me, and that's the end.
Thank you. That was very powerful and moving, you know, and I remember with Lynn, we should dedicate the session to all the lives that have been needlessly lost because of punitive drug policies. And it's such an important message that naloxone is about, you know, people have a right to live and to live well and to be supported to use drugs and to use drugs safely. And so I think it's great. We've got about 25 minutes in which to continue this conversation. And if anyone has any questions for Lynn, please ask them, and then maybe we could take questions for all of the panelists together about anything that's come up. So, yeah.
It's not a question, it's just I want to share my feelings. I'm very proud about all of you. I'm very proud about my peers. We are pioneers in harm reduction. We should never forget that, and we must be united, and we must be really resilient, because we are facing tremendous challenges every day in our work. Okay, I have to introduce myself. My name is Marios Atgemis. I work for Positive Voice, the Greek Association of People Living with HIV, but also I represent several European networks here for HIV and drug policy issues. I'm a peer worker, probably one of the most privileged, because I work in a very tolerant environment regarding my organization, about drug use and sometimes about my chaotic behavior, but that's okay. I just wanted to share that everything you shared here, it's part of our everyday challenge, especially naloxone. We are losing people. Every day I lost some of my very good friends for nothing. I almost lost my life for 2 times because the ambulance did not get me because I fainted in an open drug scene. And I was very lucky that my friend was with me, and he actually threatened them that I will tell everyone, you know, to television, that you don't come here because he's a junkie and we are in the middle of an open drug scene and he will die. So I have the luck to be with you today. Also, I have to share some very basic things about our work. We are doing a massive amount of unpaid work, okay, and that's trouble. We must be very resilient because we are surrounded from a hostile environment, let's say, and we are facing 2 different kinds of people. The gatekeepers, who are the state officials, who are perceived as a threat sometimes, and they stopped us from what we're doing. And second, from the professional saviors. I call them people who have nothing to do with our communities, nothing to do with our job. They just care for their career and their money, and they try to use us as tokens. Okay, I spit on both of them, actually, and power to the people who use drugs.
Thank you. I'm never going to forget that. Professional saviours. Very good. Who else? Who else would like a comment or a question? Matt?
Yeah, Lynn, thank you really for this presentation, and it's so good to have ISCA back organising with the European network again, alongside as one of our oldest drug user networks. Ireland is a country that's changing a lot in terms of, religion used to be very significant and it's now shifting, and there's a real changing attitude among people's identity in Ireland. Is that changing around drug taking as well? How's the shifting conversation with the changing identity? Is there also a sort of changing discussion around drugs and harm reduction?
I mean, I know there's people in this room that could answer that a little bit better than me, just because I've only lived in Ireland for 5 years. But I definitely, when I started working as a relief worker to now, I've already seen it change in certain ways. So I'd say it is changing. You know what I mean? And for some, it's never quick enough. But I think it is changing and improving, and yeah.
Anyone else? And now I think we could open it up more broadly. So if anyone has any questions or comments for anyone in the panel? Yep. And please introduce yourself very briefly.
I'm Astrid from Germany, Berlin, and I think that the naloxone is one basic issue to spread all over opiate users communities. But we know that there's a rising number of fatal situations not caused by opiate overdoses. And so I want to ask you if you have discussed this issue. It's the heart attacks and embolism. And we experienced a fatal overdose where naloxone has been applied, but it did not make sense. And so that's really bad for the image of naloxone. And I think about how to look forward, be prepared, or still keep in mind the fatal situation after too much cocaine. And we should do the next step now. And please, what's your discussion now?
So, of course, I said several times that I was talking about opiate overdose. Then we got benzos or stimulants overdose. And for instance, in Portugal, we can reverse already an overdose of benzos with flumanzenil, but it's medically restricted or available in safer spaces for using drugs. That means drug consumption rooms. So the wide availability of drug consumption rooms would actually decrease the number of overdose either on benzos or even stimulants that we are talking about prescribed medicines such as diazepam. So when we arrive at this discussion, I think there are ways to provide. I've seen in my front that a nurse could not inject actually during an overdose of benzos, flumanzenil to a person, and a peer could did this, you know, and I've seen this happening. So I guess we could also thinking about decentralize this kind of medicines. Also regard stimulants use. I don't know if you've heard that here in the conference we have also a safer space for consumption. It's in the 9th floor, room 902. And there are visits today at 1 p.m. and at 7 p.m. for those that want actually to inject, sniff, smoke. Maybe, yeah, it can happen. Sorry, maybe I should have shut up. But well, I guess we are in between friends, and you can get some naloxones there, and maybe we could discuss further these availabilities and spreading out other medicines such as flumanzenil or diazepams.
Thank you. All right.
Thank you. I'm going to take this off. My name is Kata, and I'm with the Danish group, but I'm a spy among them because I'm actually from Hungary, Eastern Europe. So I constantly see the differences between good and bad practices. And I think I just want to ask, like, how often is that when someone calls the emergency lines, for example, for an overdoses, that the ambulance won't respond because they're not going to come? Because I know that in Hungary it is actually a case sometimes that they just like, oh, we are not going to come. I don't know who can answer this. I just wanted to put out that question.
From what we've heard from people in Dublin and from our direct experience, sometimes it's not a matter of sometimes the ambulance will show up, but it takes a longer time. And also there's a big problem with emergency dispatch staff maybe not being trained on naloxone or telling people to give them the whole 5 doses at once. Do you know what I mean? Which can be horrible, you know, for people. So training of emergency services staff, I think, is a big issue. And I mean, over the pandemic, we definitely saw delays in emergency staff showing up. From our experience, I'm sure it was the same all over.
So we've got about 10 minutes left. Are there any last questions before I ask everyone to have a final reflection? Matt? No?
Hi, I'm Neil Woods from the Law Enforcement Action Partnership. I'm just wondering, do any of you have significant barriers or problems from police? And if so, do you have any tips in overcoming those barriers?
Great question. And then maybe you could, talk with them to help develop some ways forward with that.
So speaking not about Portugal but Italy, because I'm Italian, I'm switching between Portugal and Italy. Our law says that Naloxone is it's very cheap, almost €3, something like this. It should be available in every pharmacy. It's not. And about police, the problem is that when they come with the ambulance, they come with the police too. And every people in the surrounding got revistado. Search, thank you. And if you have something, our laws are very prohibitionist. So this is what happens in Italy.
And in Portugal, depending on the quantities, but actually since 2008, the Supreme Court decided that it's cumulative. So, for instance, if I'm going to somewhere and I'm carrying with me 5 grams of ash, 1 gram of speed, and then for partying, I don't know, 1 gram of heroin or 2 grams of cocaine, it's already a crime and I can go judge in court because I'm overcoming the quantities that are kindly random decided since the 1993 law. So that will be 5 grams for hashish, 25 grams for cannabis, 1 gram for heroin, 2 grams for cocaine, 500 micros for LSD, 1 pill for ecstasy, and so on and so on. So it really depends on the police officer that also comes to you. I've done like several researches regarding street use and then party settings, and especially in party settings, when arriving or leaving festivals, it's very usual that a person or end up in court if caught up with substances, or ending up in the commissions of dissuasion of addiction, that actually 90% of the people that go there don't have any problems with drug use, very normalized lives, but still have to go through a psychologist and social worker process so they can decide if we are problematic users or addicts, or if we are normal drug users. Well, not being a drug user. Usually you just lie. You arrive to a commission and you just lie.
Thank you. I would just quickly respond to your question, because I have a bit of experience with calling ambulances quite often, and I think what actually often helps is to precisely phrase the description of the state that you find the person in. That, for example, if the person would have a heart attack and you would tell the dispatcher or the person on the phone that the person has chest pain, they have difficulty breathing and left hand shivering. In Czech Republic, they have a responsibility to make sure that it's not a heart attack, and they have to respond. So it helps to, for example, with an opioid overdose, to help that they have a really big difficulty breathing, that you're afraid that they will stop breathing. And in that scenario, if, of course, they can say, okay, well, we just won't come. But if they do that, they have it's written in the law that they acted against the law. And of course that you probably won't pursue this lawsuit because it's just really complicated. But that's an argument that sometimes really works.
Yeah, very, very big. We teach our peers exactly the opposite. When you phone to 911, tell them that the guy or girl in front of you had chest pains, hard to breathe, and of course pain out on the left, or anything which you could teach about a heart attack, because then they'll come as a priority one, and they won't have the coppers with them. So it's different in different countries, but that's the only way to get them out. If you will say there is an overdose, automatically, because of the ambulance union, something won't go in without having police, blah, blah, blah. But if you have a heart attack, even if you're a drug user, you're a well-known address, they'll come as a priority one, and they can't just neglect this. So different countries, different ideas.
So Neil, just give you one optimistic story. So one of the peers in London who gives out Naloxone, he told me a story of being stopped in the street by two police officers. He actually had just brought heroin, so he had heroin in one hand. He was being searched, and the police were working their way down towards the hand that was holding his heroin. Another police officer was going through his bag. As the one police officer got to hear the other police officer found the Naloxone in his bag. And at that point, he went, "Oh, then Naloxone peer educators, leave him alone, on the way." And my friend is going like this. So maybe a more optimistic story. And it's not the only time I've heard this. There's a sense that carrying Naloxone gives you a different dialogue with the police. They're suddenly seeing you as educators, not as big criminals in the same way.
Antoniu, about Catalonia, if I'm right, they give a take-home Naloxone, and they give to the user, I think so, like a ID, saying that he is allowed to carry a Naloxone kit. That's right. That can be a very useful way to make a clearly position
Yeah, that's right. The problem is we have not nasal naloxone, only the glass little bottle of naloxone. Intramuscular. But it's extended to all the community. It's not prohibited to bring with you. Even so, the emergency systems are perfectly coded. When you phone and say this is an overdose, it's okay. And they have a training as well with the Department of Health to specific with opioid emergency.
Okay, and another thing about the Naloxone program, take home in France, you can get it in all the OST centers and in the Carrud, which is a needle exchange place. You can have Naloxone too.
Thank you. Okay, I'm aware that we're pretty much at end of time, but I want to thank everyone for an amazing session, and it's brought up a lot of thoughts for me. Also, harm reduction isn't obviously just needle and syringe and naloxone. A couple of the presenters, Antoniu and Emilia, mentioned supporting people getting housing. Right? And I think we need to be ambitious and think more broadly and learn from each other and learn from the peer networks about how to do these other things. And then you probably have, in different places, there are issues about marginalised communities being moved on because of community gentrification, things like that. So how do we support peers in mobilising to prevent broader structural harms from happening? I think, Antoniu, one thing that fascinated me about your discussion was your connection with the media. And if we had more time, but perhaps maybe in lunch, people could talk about that you notify the media and you obviously have a good relationship with the media. And I think, that's what an amazing success. Because the media often vilify people who use drugs and are responsible for a lot of the broader community misperceptions about peers. So there is lots more to discuss, and I just think before we go, I'd like everyone to close perhaps maybe on a reflection of the session, something the network that you're proud of achieving as a network, or a challenge a last thought, and then we can all go for lunch.
Can I go last?
You can go.
Thanks.
Or something that you would, that the networks need. Money. What would you need to achieve, your next dream?
For me, the biggest challenge is how to raise money. And one of the things, for example, in my town with the municipality is 20 years of relations, at least. For example, after the lockdown COVID, nobody wants to go to the neighborhoods where people is using on streets. EHRC did it. And then after the COVID emergency, we received a call from the public health of the municipality saying, I don't want to hire anybody, it's not yours. This job is, from now, is yours. And then we receive a part of this project, a half-part job for a drug user in our structure. And this is very easy because it's a contract, but in other part, if you raise money from the municipality, they accept that we pay in black money people. It's not registered and it's only in our books, not it's public. We have an invoice for all over the year, and they don't ask us how you pay your workers or etc. This is an exceptional situation, but we have to find some ways to raise money, for example, for foundations or other kinds of money, because we are able to set up new structures to pay people, and that we did it with another situations in our life, but to be drug users it's not more difficult. And then we have to be honest and in your organization, and the count's clear, but it's not such a difficult thing. We have to think on money, where is the money, and put in the community, and then you arrange things. On the other hand, people who working in EHRC is earning money from the state, social state, for hepatitis, etc. And sometimes if you pay in official money, interact with this money and get punished for the treasury of the ministry. This is a problem, for example.
Got the same problem. For specific funding, as I've said before. So in this kind of flexibility that Antoniu referred, I think we all want to pay our peers. At least I don't work with peers without paying, not even voluntary basis. So every week we are also with Magda, she's here, taking a peer-led support group among women that use drugs, like us, that do sex work, migrants, homelessness, women with HIV, youngsters, And for instance, for this project, we got some municipality funding through the mobile drug consumption room, but it's a new kind of having this flexibility and passing informal receipts that is no longer in time, so it should be finishing any second. And yeah. And then we had the contribution of EuroNPUD through the campaigns, the small grants, and UISCE, I see Isher there, that is allowing us to set up this peer-led project that actually women that are our peers are paid every week for the capacitation and training. And hopefully we would need a safer space so we could give continuity to this peer engagement, and that these women could actually work and deliver the harm reduction they are learning from own experiences, communities, exchanges in between all of us. So that's it, different kinds of funding directly to peer-led responses.
No, I just wanted to say Joana knows well better than me the Portuguese context in this case. From CASO, yes, from the beginning we had a strong connection with UpDash, but just with the small grants we are trying to redistribute all the money in the community. And yes, this is a huge effort and a big challenge for the future, especially after the pandemic.
Yeah, I'll just echo exactly what they just said. Funding and exceptions and peer-led around all of it.
And finally, I think that we have to be creative because, for example, we got a lot of money selling chestnuts for the 1st of November day. This is a tradition in our city. You can raise 500 euros, for example, in 3 days selling chestnuts because we can sell t-shirts or what to do and have your own cash. It's not control for nobody. It's not. It's only a proposal.
Thank you everyone. Thank you to our wonderful panel.